I made this joke last year, and I'm going to make it again because every time I wear a mic like this, I feel like I should be selling like blenders or vacuum cleaners or something. So bear with me. Thank you for that very kind introduction, Pat. I'll try not to mess this up after that. And I would thank the Leukemia Research Foundation for inviting me, and I would also say as a young faculty, I feel pretty honored to be up here talking along with some other leaders in the field that have been doing this for a lot longer, and kind of the footsteps that I feel like I've built my career on and learn how to take care of my patients. So I'll be talking to you today about multiple myeloma, a disease that really, I've been fortunate enough to really watch grow and flourish as I did my training and now as I've become faculty. The number of new drugs that have been approved for this disease can be overwhelming, so I'm going to try to help you sort through some of that and just kind of give our approach at Loyola and my approach, how we're approaching the disease. So this is an outline what I'll go over. I'd like to start briefly talking about the history of the disease, because we've really come a long way recently after many, many decades of not a lot of progress. I'll go through new drugs. I'll talk a little bit about risk, because that really matters as we're approaching our patients. I'll talk about kind of what I believe is the standard of care right now in the upfront setting for both our fit and less fit patients. Finish up with how we're approaching relapsed and refractory disease, and talk a little bit about some exciting developments, and then show you how far we have come most recently. So this is the case report from 1844. This is the first ever reported case of multiple myeloma in the literature. This was a young woman, Sarah Newberry. She presented, like many of our patients do even today, with fatigue and multiple bone fractures. Ultimately, she would pass away 4 years later from her symptoms. And these are the drawings from the medical journal of her disease. I put this in here partly to wake everybody up because I was the first talker, but just to show you in the past, this disease was really, really bad. And many times patients presented in tough shape and we couldn't do much for them. The initial treatments for the disease were things like rhubarb, orange peel infusions, Dover powder, which is basically opium, and actually leeches, which was actually the first maintenance therapy in multiple myeloma, something that we use today as part of our standard of care. Thankfully, we've come a long way, but it didn't happen until very recently. So this was in 1845. Really not much progress would be made in this disease for a century. In 1847, there was a case of a patient being treated with urethane, which is basically a chemical insolvent, and we saw the protein levels in the blood go down. That actually became the standard of care for about 20 years. In the late 1950s, our first really good drug started to be developed, a drug called melphalan, which if anybody in here has been treated for multiple myeloma knows a fair amount about. In 1962, we would really first show the efficacy of corticosteroids in treating multiple myeloma. And when added with melphalan, it increased responses and patients started to do better. The first randomized trial that was ever done in multiple myeloma was published in 1966, and this compared urethane, which I mentioned a couple moments ago, to actually a placebo, to Coca-Cola. As you can see from these curves, is my mouse showing up? No. As you can see from these curves, there was no difference. So urethane doesn't work. Thankfully, there would be some more progress. We would soon start to combine melphalan with steroids, first published in 1969. And then subsequently, the first really big breakthrough would happen in the late 1980s in multiple myeloma, where we looked at the first kind of large series of autologous stem cell transplantation, which is where I specialize in the treatment of the disease. And they showed that about a third of patients who went through this procedure went into a complete remission where we couldn't detect the disease anymore. So this was an enormous breakthrough and remains part of the standard of care today, 30 years later. In 1997, really the first new drug that would be developed for multiple myeloma in almost 3 decades, and that was a drug called thalidomide. It was developed because we noticed that it had some anti-angiogenic effects, which means it affects the way the blood vessels grow and interact with the tumors. And that was unfortunately the cause of some birth defects that we noticed when it was used in pregnancy to treat nausea. This would be developed down by Bart Barloghi down at the University of Arkansas. Shortly thereafter, in 1998, really our new drugs started to come into play. These are drugs that we're using still today. Bortezomib, which is a proteasome inhibitor, was developed and started to be investigated. And in 2002, the first phase 2 trial of this drug would be investigated, and it would ultimately lead to its FDA approval in 2003. Shortly thereafter, lenalidomide would be developed and would be FDA approved in 2006. So bortezomib and lenalidomide are part of our standard induction therapy currently, and this really changed the game in how we treated the disease It improved responses. These drugs were much better tolerated, and really has become today as part of our standard of care. So what are some of our other approved drugs in the treatment of multiple myeloma? So our alkylating agents are still a backbone of the care. I mentioned melphalan. Some of the early developed drugs are a drug called cyclophosphamide, a chemotherapy drug that's used to treat other hematological malignancies. Later, we would incorporate a drug called busulfan into some of our conditioning regimens, meaning the chemo we give with transplant. And we've seen some actually improved outcome and is currently being investigated. Furthermore, a drug called melflufen, which is a different iteration of melphalan, is being currently studied and has been shown to be very active and overcome some of the resistance that we see with some of our standard chemotherapy. I mentioned our proteasome inhibitors. So again, these work by inhibiting the proteasome, which basically causes the cancer cell to become stressed, and ultimately the cancer cell dies. So bortezomib was the first drug developed, but we've developed a couple of new drugs in this drug class. A drug called carfilzomib, which is commonly used both in the upfront and when the myeloma comes back, as well as a pill form of this drug, a drug called ixazomib or Ninlarno, which for patients who struggle to come in and out of the clinic frequently is very effective and is used frequently. There are other proteasome inhibitors still in development listed here at the bottom, so more to come. Our immunomodulators are another big class of drugs. I mentioned the lenalidomide in its first use in the early 2000s and FDA approval in 2006. The lidomide that was also mentioned earlier, and then pomalidomide is another newer generation immunomodulator that we often use when the myeloma comes back after it's initially treated. And then our monoclonal antibodies are really the new players on the block, and these have really dramatically changed how we treat the disease. These drugs actually target different proteins expressed on the myeloma cells, and they engage your immune system to do the work for you. Because of that, we see less toxicity, and these drugs are now able to be combined with multiple other drugs, and we see more effective treatment, and we see less problems for our patients. Elotuzumab was the first drug that was approved in 2015. Daratumumab would shortly follow the following year in 2016. And there are others such as isatuximab and several others in clinical trial development. So this was a big step forward for us. This was a trial, and I'm going to get to when the disease comes back, but this was a trial published in the New England Journal of Medicine in 2016 that looked at the combination of daratumumab with two other drugs, lenalidomide and dexamethasone. And what we found that these drugs were well tolerated, that there was basically similar levels of side effects when we add daratumumab, which is one of our new drugs, to lenalidomide and dexamethasone. Furthermore, it's convenient. While it's given weekly at first, ultimately it can be given monthly. And soon it will no longer need to be given IV after the first dose. Soon we'll be able to give it subcutaneous. So as you can imagine, being able to come into the clinic, get a drug that's well tolerated, can be given as a subcutaneous injection, you don't need an IV, and is extremely effective treating the disease has really changed the paradigm. So one quick comment on myeloma and how we look at the disease. So every myeloma patient is not the same. How we risk stratify our patients when they come in is critically important, because some patients do very well and go years and years and decades. Other patients, the disease comes back very quickly and is tough to treat. And we do this by using this staging system. It's called the Revised International Staging System, and it's evaluated by several blood tests and ultimately a bone marrow biopsy. And we know that there are certain high-risk features of this disease that need to be treated aggressively and probably need to be treated differently than our standard patients. And these are patients who have certain high-risk changes on the genetics of their myeloma cells, so not the genes that you're born with, and some serum blood tests, such as an elevated LDH, that we know dictates patients who are likely to do poor. And so these are important discussions to be having in the clinic with our patients, so the expectations are there. And also I would argue that these are the patients that probably should be on clinical trials to try to look for new ways to improve outcomes. And as you'll see, particularly in our high-risk patients, although the outcomes have dramatically improved in the treatment of this disease, only 40% of these patients are alive at 5 years. And we've come very far in the treatment of this disease, but it shows us that we still have a far ways to go. Importantly, this risk stratification that you should be discussing with your doctor is applicable to all settings. So this is basically showing the blue curve on top is the low risk, so stage 1. The yellow is an intermediate risk, so stage 2. And the kind of light bluish, purplish curve is stage 3. And as you can see, for patients heading to transplant when they're originally diagnosed, for those not heading to transplant, for those who are treated up front with our immunomodulators like lenalidomide, and for those who are treated up front with our proteasome inhibitors like bortezomib, outcomes are consistent. The bad players do poorly, unfortunately. So this is applicable no matter where you are in your life, your disease status. These are important conversations. These are things to be aware of as you're thinking about your disease and how it should be approached. So upfront therapy. So I'd like to go through currently what is the standard of care, more or less, although there is controversy, and how we're approaching our patients. So I would say first and foremost, I wouldn't be doing my job if I didn't say we would encourage all patients to be on clinical trials. Clinical trials is how we've improved the treatment of this disease. It's how we will continue to improve the treatment of this disease, and we can't do it without you. And so these are discussions, again, you should be having with your doctor, and you know, at every step of the way, it's important to consider the standard of care, but also the options to be on a clinical trial to potentially improve that. It's also important to realize that myeloma is a chronic disease. Outside of a few small patients, every patient's disease will come back multiple times throughout the course of the disease. So it's important up front that you understand that so you have good expectations. So right now I would argue that the standard of care for a fit myeloma patient, so this means somebody who we would consider a transplant candidate, is induction with 3 active myeloma drugs, followed by a stem cell transplant, and then after the transplant to be on a maintenance drug, typically lenalidomide. In an unfit or a transplant ineligible patients, essentially everything that I just said is the same, removing the transplant piece. So ideally we want these patients on a combination of 3 drugs if they think they can tolerate it. We would dose modify those drugs based on their tolerance and how we think they'll do. And we would generally treat, in my opinion, until the disease grows or comes back, as long as the patients are tolerating the treatments. We know time and time again, if we stop myeloma therapy, the disease comes back. So if a patient is doing well, tolerating the treatment without side effects, can afford the treatment, and there are no barriers, they should stay on therapy. How do we know this? So we've looked at this over several studies over about the last decade, looking at a combination of 3 drugs versus 2. So these are some curves from a SWOG study, a Southwest Oncology Group study, that looked at what is, for most patients, has become the standard of care, RVD, which is lenalidomide, so that immunomodulator pill, Velcade or bortezomib, which is one of the proteasome inhibitors, and dexamethasone, which is a steroid. So that was compared to basically just the lenalidomide and the steroids. And what did we find? An improved time to the disease came back, 43 versus 30 months, so about a year and a half. We found that patients live longer, they survive longer, which is obviously our most important goal here. And ultimately it's becoming harder to show with our better therapies that patients can go on when the disease does come back. And this really, in my opinion, established the standard of care. There are several other studies that I could show you that looked at similar 3 versus 2 drug combinations, and the outcomes are consistent. So if you can be on a combination of 3 drugs, you can tolerate it, this should be how you're treated. So what about the transplant piece? So this is data from the CIBMTR, and what this is showing is that over time, so as you go through time to more recent times, we're doing more and more transplants. The top left graph is showing this yellow portion is patients who are over 70, green is patients who are between 60 and 70, and the blue is those who are under 70. So as you can see over time, we're doing more transplants for myeloma in all ages because we can do them safer, we can get patients through them, and we know as this data has matured over the past decade that this should be the treatment approach. Furthermore, myeloma is the commonest indication for transplant in the world. So if you look at the breakdown, autologous stem cell transplants for multiple myeloma is by far the commonest transplant we're doing. We're doing it safer, and this bottom graph shows that over time, the bottom blue line is the distant past, so 2001 to 2004, up to the most recent times. You can see as that bar goes up, as time gets closer to current day, outcomes are steadily improving. So this is an important thing to understand. So why do we do transplant up front for multiple myeloma? Because the outcomes are better. So this is a list of 4 randomized controlled trials that have been done and published recently in the last few years. And these are all trials where patients got kind of our more standard induction therapy, our new good drugs. And the patients were randomized to either get a transplant up front or to get it when the myeloma comes back. And consistently, we see a year to a year and a half advantage before the myeloma comes back. And although not consistent, often there's a survival advantage. Again, this is becoming harder to show because when the myeloma does come back now, we have much better drugs to treat it with. Furthermore, when you get a transplant up front, I would argue that there is an advantage in quality of life. Although quality of life takes a dip during the time of transplant, afterwards you're off your therapy, you're not in the clinic every week, you're not in getting treatments every week. So depending on what you're doing after the transplant from the maintenance piece of that, I would argue that there is an improvement in terms of your quality of life. So post-transplant, why do we do the lenalidomide maintenance? Again, myeloma is a chronic disease. The lenalidomide actually engages the immune system to keep the disease in remission for longer. There's been a large meta-analysis recently done looking at several trials where patients were randomized to get maintenance lenalidomide or a placebo. And what we're seeing is when we do this maintenance, we get another 18 months of time before the myeloma comes back. Furthermore, this meta-analysis showed that likely there is a survival advantage of the lenalidomide. Again, between trials, it's inconsistent, but when we look at all the trials that have been done and we combine them together, that likely patients are living longer when they're getting the lenalidomide after the transplant. What are the next steps? In my opinion, and this is being currently investigated, is risk-adapted maintenance. So our patients who are higher risk should be on a more aggressive approach after the transplant. Perhaps patients that are lower risk should be on a less aggressive approach. And with our better means of detecting the disease, our hope is that we can show that if you get into a deep enough remission that we can stop the maintenance period and you can do just as well as if we were to continue it. And this is actively being investigated right now. So that's the fit patient. What about the unfit patient? Again, a lot of the same principles apply here. So we have to be very mindful of tolerance and comorbidities, meaning if you're a diabetic, we have to watch our steroids. If you have heart problems, we need to be careful with the drugs that can affect the heart. So it's important that we're looking at all these things as we're starting our therapy. Importantly, our new and better therapies are moving up front for these patients. Those that we can't get a transplant, we really want to get our best drugs, our best tolerated drugs into patients earlier so they do better. And again, we treat until progressive disease. So this is a pretty impressive study that was just published or just presented at ASH. This study was called the MAIA study. And I talked to you about that daratumumab, that monoclonal antibody. So this looked at patients up front who were not fit for transplant. They either got lenalidomide, so that pill, same pill, and steroids, or they got the same treatment plus the monoclonal antibody. I would point out two things here, if this isn't coming up very clearly, but those who just got the lenalidomide and the steroids had a median time of 31 months before their disease progressed. That's impressive. That's a very good control. And if you look at the patients who actually got the daratumumab infusion, we don't even know how long they went before they progressed because we haven't gotten there. It's going to be a long time. Again, these are upfront treatments for patients who are not as fit, and we're seeing very impressive results. These results would have been unheard of 5 or 6 years ago. A quick note on supportive care. This is a critical aspect of the treatment of myeloma. Again, a discussion you need to be having with your doctor. Patients need to be on calcium and vitamin D supplementation to strengthen their bones. They need to be on medications to further strengthen their bones. Bisphosphonates or rank ligand inhibitors. These prevent skeletal-related events, so these are fractures. These fractures in myeloma have huge impacts on quality of life, if you remember that picture I showed you in the beginning. Patients need to be on aspirin or low-dose blood thinners to help prevent blood clots. And they need to be on antiviral therapies to help prevent infections, things like shingles. So quickly, as I'm running out of time a little bit here, so in terms of relapse and refractory myeloma, again, a lot of the same principles here. We encourage patients to be on clinical trials. We're doing a lot better, but we could do a lot better than we are. 3 drugs are still better than 2, even when the disease comes back. So if you're a candidate and you can tolerate it, that's what you should be on. We treat till progressive disease, and there's an ongoing need for supportive care. We have a lack of head-to-head clinical trials when the disease comes back. So we really don't know which combination of 3 drugs works better than others, but we're looking into this, and as academic medical centers, it should be our job because the industry is not going to look into this. So this is an area of further development and more to come. We don't know if there's the best treatment approach, and again, treatment is tailored to tolerance and the comorbidities. So we have to be mindful of drugs like bortezomib with neuropathy, drugs like carfilzomib in patients who have high blood pressure and heart problems, and steroids with things like high blood pressure, high blood sugars, and fluid retention. The studies are the same in the relapse setting. So when we look at 3 drugs compared to 2, we see the same outcomes as we do up front. So when we look at KRD, a combination of carfilzomib, again with lenalidomide and dexamethasone versus just the lenalidomide and dexamethasone, significant improvement, 26 versus 17 months. Similar outcomes were seen when we looked at a drug called elotuzumab, one of the monoclonal antibodies that treats the disease. So 3 is better than 2. Although we haven't compared regimens up front, there is some emerging data that might give us some ideas. So this was a very large meta-analysis that was just recently published last year that showed amongst all the combination of regimens that have been recently evaluated, a combination of daratumumab, lenalidomide, and dexamethasone likely has the best outcome. Again, this is getting a little bit trickier because these drugs are getting moved into the upfront setting, so once a patient has progressed on those drugs, we might not be able to use it when the disease comes back. But ultimately, several of these regimens are looking very promising in terms of how long patients are going before the disease progresses. A few other important things to consider: a second transplant. I would argue anybody who goes at least 18 months, and definitely if you've gone 36 months or 3 years after your first transplant, you should be reevaluated for a second transplant. And allogeneic stem cell transplantation, although I'm not going to dive into this controversial topic of multiple myeloma, for our very high-risk patients, particularly if you're younger and if you're in a good remission, this should be a treatment that you should consider and discuss, because it is the only treatment thus far that has essentially showed cures in this disease, but it's a risky treatment and it has a lot of side effects, so something that should be discussed and be aware of. So finally, a few final quick thoughts. There are some other drugs that are being developed. I talked to you about melflufen, so this is a newer generation of melphalan. It's currently in phase 1/2 studies with phase 3 studies ongoing. Selinexor is another new drug that's currently in investigation. It's been shown some pretty promising activity in heavily pretreated patients. So there are clinical trials ongoing, and this drug is potentially going to be approved, although we're not certain at this point. Ibrutinib, a drug that's frequently used to treat lymphoma, is currently being investigated in phase 1/2 studies. Some learning points that are some surprises and some learning that we've done recently. Some drugs that have looked good ultimately haven't panned out. So our checkpoint inhibitors, or drugs like pembrolizumab, were found to basically not be safe in multiple myeloma due to infection problems. And recently, a drug called venetoclax, which is a BCL2 inhibitor, it gets really at the B cells. Although we thought looked promising, ultimately these trials are recently stopped due to safety concerns. There are a number of drugs that are in development and in clinical trials that are looking very promising. Things like BiTEs and CAR-T, monoclonal antibodies that are targeting different things like CD56. We're looking at HDAC inhibitors, PARP inhibitors, BET inhibition. I mean, this list is only partial. It could go on and on. And finally, hopefully I don't steal Pat's theme here, but CAR-Ts have really garnered a lot of attention recently in myeloma. They're investigational currently, but they're promising. It's essentially a type of therapy analogous to a mini autologous transplant, where patients' cells are collected and then taught essentially to treat the myeloma and then reinfused. Current targets that we're looking at are BCMA and SLAM7. They're very early but promising results. This was a New England Journal paper that potentially Pat might show you in a little bit, or Dr. Stiff, but this looked at BCMA as a CAR-T target. This was a phase 1 study. These patients were heavily pretreated, so 7 previous regimens. We had, CAR-T does have some unique toxicities, but these were kind of in par what we had seen in lymphoma. And we saw pretty unprecedented results with CR rates of 45% in patients who have gone through 7 lines of treatment and a progression-free survival of about 11 months. Patients are still relapsing though, so this is a chronic disease. Even if this treatment looks good, I'm skeptical it will cure our patients, although I'm hopeful that potentially we'll have some. But still, the lesson is it's a chronic disease. And then my last slide here is this recent updated SEER registry data. This is looking at 3 different patient groups: those who are less than 65, 65 to 74, and those greater than 75. These 3 different columns in each of these age groups are different ethnic groups. And as you'll see, this red is the oldest time period, the purple is the newest time period. Survival is improving in every single age group, every single ethnic group. This is a critical take-home point. So our outcomes are getting better. I expect them to continue to improve. We do have a long ways to go, though. And with that, I'll stop and thank you for your attention. And sorry I ran a little bit over.